Hello everybody, I'm Dr. Khulus Salim Salami. I am an assistant professor in the Department of Obstetrics and Gynae. Our lectures today is about the female pelvis and fetal scalp. This lecture actually is a refreshing lecture regarding your knowledge about the anatomy of female pelvis and fetal scalp. The objective of this lecture is just to know the different type of female pelvis. Actually, we have 4 different type of female bony pelvis, and to know the different bony parts which form the female bony pelvis and their diameters, to know the bones which is forming the fetal scalp, their longitudinal and transverse diameter, and the effect of this diameter on the mechanism of labor, and to understand the changes which may affect the fetal scalp, like molding, cryptococcygeum, and cephal hematoma, and the effect of these changes on the progression of labor. To start with, as we say, we have 4 different types of female bony pelvis, and these are the following. The most common type of female pelvis are the gynecoid pelvis, and from its name, gynecoid, it means a female type of pelvis, and this form about 50% of female pelvis. It is the most common type, and all our discussion regarding the female pelvis involving this type of pelvis. The second type of pelvis is the android type of pelvis, and as we from the name, the android pelvis, it means the male type of pelvis, and it about 20% of female may have this type of pelvis, in which the pelvic inlet or pelvic cavity, it is heart shape of pelvis. The pelvis is similar to that of the heart. The third type of pelvis is what is called the anthropoid pelvis, in which the pelvis is narrow from side to side, while the anterior-posterior diameter is much longer than the transverse diameter. While the fourth type of pelvis is the platyploid pelvis, in which the transverse diameter is much greater than the anterior-posterior diameter. All the different type of pelvis, apart from the gynecoid pelvis, is usually associated with malpresentation of the presenting part and prolongation of labor. Again, as we say, that all the things we are going to discuss regarding the bony pelvis is involving the gynecoid pelvis rather than the other different part or types of pelvis. The female bony pelvis are formed from the hip bone, and this hip bone includes the ilium, which is present on either side. This is the ilium, the ischium, and the pubic bone. Then we have paired of the pubic bone, paired of the ischium, and paired of the ilium. In addition, we have the sacrum. This is the sacrum, and the coccyx. The pubic bone are joined anteriorly by the symphysis pubis, while the sacrum are joined with the ilium on either side by the sacroiliac joint. This is the sacroiliac joint. This is the bones which is form the female bony pelvis. The female bony pelvis have 2 parts: the true pelvis and the false pelvis. The false pelvis is also known as the pelvis major or the greater pelvis, and this type of pelvis is bounded anteriorly by the abdominal wall, posterolaterally by the right and left iliac fossa, while posteriorly by the 5th lumbar vertebra and the 1st sacral vertebra. And for that reason, usually the false pelvis is mainly related to the abdomen and have nothing to do related to the obstetric, while the most important part is the true pelvis, or what is called as the lesser pelvis or pelvis minor. We can imagine the true pelvis just similar to a hall or a room. It has a pelvic inlet or a pelvic brim, which is similar to a door. It has a hollow or a cavity, and it has an outlet or an exit. Usually, to start with, we will discuss few points regarding the cavity, the pelvic cavity and outlet, and details for the pelvic inlet. The pelvic cavity of the female pelvis is formed by the hip bone, which is the pubic bone, the ischium, and the ilium, in addition for the sacrum. And from the picture we can see that the pelvic cavity is rounded in shape, in which the anterior-posterior diameter and the transverse diameter are equal to each other, and it is about 11.5 centimeter. The pelvic cavity, it is the part where the pelvic organs are situated, and including the urinary bladder, the rectum, in addition for the uterus and the ovary. This is the pelvic cavity. While the pelvic outlet, seems to be diamond in shape. As you see, it is diamond in shape, and it is formed or made up from the pubic bone. This is the pubic bone, from the ischium, the ischial tuberosity, and the sacrotuberous ligament, in addition for the fifth sacral segment. This is the fifth sacral segment or vertebrae. And as you can see, the anterior-posterior diameter of the pelvic outlet is about 13.5 centimeter, while the transverse diameter is much smaller, and it is about 11 centimeter. This is what is called the pelvic outlet, which is diamond in shape, in which the transverse diameter is much smaller compared to the anterior-posterior diameter. The most important part is the pelvic inlet or the pelvic brim, which is very important. Why? Because the pelvic brim or the pelvic inlet is the part in which, when the presenting part is passed through, when the largest transverse diameter of the pelvic part is passed through the pelvic brim, we consider the presenting part being engaged. The boundaries of the pelvic inlet can be imagined as a line. We can consider them as an imaginary plane or a line. And the boundaries started by promontory of sacrum. The promontory of sacrum is a prominence which is present in the anterior surface of the first sacral vertebra. This is the promontory of sacrum. Then there will be the ala of the sacrum. This is the ala of the sacrum. This is the ala of the sacrum. Then the sacroiliac joint. This is the sacroiliac joint. Then the iliopectineal line. This is the iliopectineal line. Then the iliopubic eminence. This is the iliopubic eminence. This is the iliopubic eminence. The upper border of the superior pubic rami. The upper border of the superior pubic rami. Then the pubic tubercle. This is the pubic tubercle. The pubic crest, and the upper border of the symphysis pubis. This is an imaginary line represent the boundaries of the pubic pelvic inlet or the pelvic brim. And as we say, that is very important because it is the boundaries by which, if the largest transverse diameter of the presenting part passes through, we consider that the presenting part being engaged, and this is usually associated with normal progression of labor. This is the boundaries of the pelvic inlet or pelvic brim. We have also the diameters or the measurement of the pelvic inlet. We have three diameters. The first diameter is the anterior-posterior diameter, and the anterior-posterior diameter can be measured as the distance between the midpoint. This is the midpoint of the promontory of sacrum of the promontory of sacrum, this is the midpoint of the promontory of sacrum, up to the midpoint of the upper border of the symphysis pubis. This is the area from the midpoint of the upper border of the pubic symphysis to the midpoint of the center of the promontory of sacrum. This is the anterior posterior diameter. While the transverse diameter is the distance between the iliobacterial line to the opposite iliobacterial line. This is the transverse diameter of the pelvic inlet. While the third diameter is the oblique diameter, which is usually start as a distance between the one sacroiliac joint, this is one sacroiliac joint, to the opposite iliopubic eminence, to the opposite iliopubic eminence. This is the opposite, the oblique diameter. This is the three diameter which is important in case of assessment of the adequacy of pelvic inlet for any female, to assess the adequacy of pelvic inlet to exclude whether or to confirm whether the uterus, the pelvic inlet is adequate or contracted, just in case to exclude the possibility of cephalopelvic disproportion. We have two important definitions that you may be encountered during your assessment in obstetric, and these are the true conjugate and the diagonal conjugate. The true conjugate also can be known as the obstetric conjugate, which is the smallest diameter within the pelvis, and it is the distance between the upper margin of the center of the symphysis pubis to the distance to the center of the promontory of sacrum, and it is about 11 centimeter in diameter. While the diagonal conjugate is also the distance starting from the center of the promontory of sacrum, but it is extend to the lower margin of the center of the symphysis pubis, and it is about 12.5 centimeters. So the only difference between the true and the diagonal conjugate, all are started from the center of the promontory of sacrum, but the true conjugate, it is the distance extend to the upper margin of the symphysis pubis, while the diagonal conjugate extend to the lower margin of the symphysis pubis. This is the things that you have to know regarding the female pelvis, the type of the female pelvis, the diameters of the pelvic inlet, pelvic cavity, and the pelvic outlet. Then we will shift to the fetal scalp. This is the fetal scalp. Actually, the fetal scalp composed of three important parts. It contains the fetal roof, Al-sabbak. This is the fetal roof, the fetal skull face. This is the face of the skull. This is the base of the skull, and this is the roof of the skull. Usually, the bones of the base of the skull, and the bones of the face of the skull, they are firmly attached to each other. The bones of the face and the base of the skull, they are firmly attached to each other, while the bone of the roof of the skull, they are attached by non-ossified membrane, and this membrane known as the suture. This is the non-ossified membrane known as the suture. And these suture are, this is the sagittal suture, and this sagittal suture is the suture which is joined between the two parietal bone. This is one and the second parietal bone. And we have the frontal suture, which is joined the two frontal bone. We have the coronal suture, which is usually joined between the two frontal bone and two parietal bone. And we have the lambdoid suture or the coronal suture, which is joined between the two parietal bone and the occipital bone. This is the suture, which is the non-ossified membrane, which join the different bones on the roof of the skull. The importance of these non-ossified membrane is allow these bones to overlap on each other and thus reduce the size or the diameter of the fetal skull during its passages through the birth canal, so that it will enhance and facilitate the process of delivery of the fetal head during the second stage of labor. In addition, the point of junction of these sutures is known as fontanelle. Then the points of junction of these sutures known as fontanelle. We have two fontanelle, the anterior fontanelle, which is also known as the brigma, and the posterior fontanelle, which is known as which is usually triangular in shape. The posterior fontanelle, as you see, it is posterior, which is small in shape, and also known as the lambda. This is the point of junction of the sagittal suture with the coronal suture or lambdoid suture, and it is usually ossified at term. The clinical importance of this suture, it is usually give an idea about the degree of flexion of the fetal head, because if the fetal head is well flexed, we maybe easily felt the posterior fontanelle during complete flexion of the fetal head, and at the same time the direction of the posterior fontanelle give you an idea about the direction of the position of the fetal head. That's to say, usually if the posterior fontanelle facing anteriorly, that means that the position of the fetal head is occipit anterior. And also it may give you an idea about the internal rotation of the fetal head. It will give you an idea, or you can assess the degree of internal rotation that the head will undergo during the process of labor. This is the posterior fontanelle or the lambda. While the anterior fontanelle, as you see, it is kit shape, مثل الطائرة الورقية. It is kit shape, and this kit shape, it is site of junction of both the sagittal suture, the frontal suture, and the coronal suture on either side. And it is usually ossified within 1.5 years after birth. One and a half year after birth. It is usually not ossified immediately after birth, but takes about 1.5 years after birth to be ossified. The clinical importance of this, it is also give you an idea about the degree of flexion. Usually it should not be palpable during pelvic examination unless if the head is extended. Then if we be able during pelvic examination, we can felt the anterior fontanelle indicate that the head is extended, it is not well flexed. This is one. Two, also will give you an idea about the degree of molding of the fetal head, the molding or overlapping of the bones of the fetal skull, and also from its position we can assess the degree of internal rotation required for the fetal head, and also we can assess the amount of or the intracranial pressure, because if it is bulging, indicate there is an increase in the intracranial pressure, and sometimes the central cerebrospinal fluid can be calculated from this anterior fontanelle, especially if the patient have hydrocephaly during labor. This is the most important, the importance of the anterior fontanelle. Okay. Now we will discuss the landmarks of the fetal skull. The landmarks of the fetal skull. We have, this is the area which is known as the sensibit. The sensibit, it is the forehead region of the fetal head. القصة. The sensibit is the forehead of the fetal head, while the occipit is the occipital bone of the fetal head. This is the occipital bone of the fetal head. The mentum is the chin of the fetal head. This is the chin, mentum, the chin. Also, we can, to be more accurate, we can, this is the area more, this is the chin, this is the sensibit, this is the occipit, this is the suboccipital area, which is this area of junction of the occipit with the neck. This is the submental area, which is the area of the junction of the mentum or the chin with the neck. This is the vertex, which is the center of the sagittal suture. The vertex is the center of the sagittal suture. This is the biparietal area, which is the area between the two parietal eminence. This is the biparietal area, which is the area of the between the two parietal eminence. This is the frontal bone, frontal point, sorry, اللي هي root of the nose. This is the root of the nose, or what is called the frontal point, while the vertical point is the center of the sagittal suture اللي هي نفسها يسمونها الvertex. This is the most important part that or landmarks of the skull of the fetus. We have three important areas in the fetal skull, and these are the vertex, and the vertex is the area bounded by the posterior fontanelle and the coronal suture posteriorly, by the anterior fontanelle and the by the posterior fontanelle and the occipital suture posteriorly, and the anterior fontanelle and the coronal suture anteriorly, and by the parietal bone on either side. Then this is the area of the vertex. This is the vertex. This is the vertex. Is the area bounded by the posterior fontanelle and the occipital suture posteriorly, by the anterior fontanelle and the coronal suture posteriorly, and on either side by the parietal eminence. This is the vertex area. This is the vertex area. We have the brow area, and the brow area is the area which is bounded by the anterior fontanelle and the coronal suture by one end, while bounded by the other end by the root of the nose and the supraorbital ridge. This area is what is called as the brow. This is the brow. While the face is the area which is bounded by the root of the nose and the supraorbital ridge in one end, and by the junction of the floor of the mouth and the neck. The junction of the floor of the mouth and the neck. This is the area of the face. It is the junction of the floor of the mouth and the neck, and the root of the nose and the orbital. This is the face. When this is the face, this is the area of the face from here up to here. This is the area of the brow from here up to here, and this is the area from the vertex from here up to here. This is the three important areas of the skull. Now, I think now we covered the areas of the skull, the sutures, the clinical importance of the sutures, the fontanelles, and the clinical importance of the fontanelle. Now we will shift to the diameters of the skull. The diameters of the skull. The diameters, we have two groups of diameters of the skull. We have the longitudinal and the transverse diameter. Now we will discuss the longitudinal diameters of the skull, and this is depend on the degree of flexion of the fetal head. If the fetal head is well flexed, that to say, the chin is attached to the chest of the fetus, that's to say the head is completely flexed, then the presenting diameter is suboccipitopragmatic, and suboccipitopragmatic is represent the diameter extend from the nape of the neck, up to the center of the anterior fontanelle or the brygma. This diameter is measures 9.5 centimeter, and it is the presenting diameter when the head is well or completely flexed, and the presentation of the head is vertex presentation, which is the smallest diameter, which is easily can be entered within the pelvic inlet, and the head is completely flexed, and the patient usually associated with normal vaginal delivery. If the head undergo incomplete flexion, then the presenting diameter in this case it will be suboccipitofrontal, and the suboccipitofrontal it extend also, it is from the nape of the neck, but to the root of the nose, and this diameter is about 10 centimeter in diameter, and the presentation is still vertex presentation, and the patient may achieve vaginal delivery. If the fetal head undergo marked deflection, then the presenting diameter will be occipitofrontal. That's to say, it is the diameter which extends from the occipital eminence, this is the occipital eminence, to the root of the nose, or what is called as the glabella, and the diameter in this case is 11.5 centimeter, which is the presenting diameter when the head undergo marked deflection. And in this case, still the presentation is vertex presentation, but usually the patient may present with a prolongation of labor and sometimes may end up with cesarean section. If the fetal head undergo partial extension, then the presenting diameter in this case will be mento-vertical, which is the diameter extend from the midpoint of the chin, to the center of the sagittal suture, and this diameter it is about 14 centimeter, and this is the presenting diameter in a brow presentation, اللي يسمونه بالعربي مجيء القصة, and this is usually a large engaging diameter which is very difficult to be engaged, and this is an indication for an elective cesarean section. If the head undergo incomplete extension, then the presenting diameter now will be submento-vertical, which is the diameter which is extended from the junction of the floor of the mouth and neck, junction of the floor of the mouth and the neck, up to the center of the sagittal suture, submento-vertical, from the junction of the mouth and the neck up to the center of the sagittal suture. This diameter is about 11.5 centimeter, and the presentation in this case is the face presentation, and usually the patient better to be delivered by cesarean section because of risk of prolongation of labor and evidence of fetal distress and difficulties in labor. If the fetal head undergo further extension leading to complete extension of the fetal head, then the presenting diameter is submento-pragmatic, which is the diameter extended from the junction of the floor of the mouth and neck. This is the junction of the floor of the mouth and the neck up to the برجمة اللي هو anterior fontanelle. From the anterior fontanelle to the junction of the floor of the mouth and the neck, and this is what is called a submento brygmatic. It is although 9.5 centimeter, but the presentation, a face presentation, nowadays in this patient with face presentation is better to be end up with cesarean section just to avoid the risk of prolongation of labor and evidence of fetal distress, and for the safety of the fetus and her mother and his mother. This is the longitudinal diameters of fetal skull. For transverse diameter, we have two types of transverse diameter. The first one is the biparietal diameter, which is the largest transverse diameter, which is the diameter extends from one parietal eminence to the opposite parietal eminence, and is account for 9.5 centimeter, which is the largest diameter. And this is the diameter which is, if it is passed through the pelvic inlet, it indicates that the fetal head being engaged. The second diameter is the bitemporal diameter, which is the diameter in which is indicate the distance between the anterior inferior end of the coronal suture, between the anterior and inferior ends of the coronal suture, the distance between the anterior and inferior end of the coronal suture. It is 9.5 centimeter. Then we will discuss the changes which undergo affecting the fetal skull during labor, and one of these changes is the molding. The molding is, as we know, is the overlapping of the fetal skull bone during its passage through the birth canal, leading to reduction in the size of the or diameters of fetal skull bone and enhancing its passage through the birth canal. It is usually physiological, it is harmless, and disappear within a few hours after birth. We have the three grades for overlapping. The grade 0, when the bones they are lie side by side and have an intervening membrane in between, while grade 1, when the bone touching but not overlapping. Grade 2, when they are overlapping but easily being separated by pressure by examining finger, while grade 3, when there will be fixed overlapping, it is difficult to be separated even by the pressure by the examining finger, and the grade 3 indicate severe molding, which may indicate prolonged labor or even obstructed labor, and have a risk of damage to the brain in such cases. Other changes which may happen during labor and affect the fetal skull is what is called as caput succedaneum. It is in caput succedaneum, it is an area of localized oedema on the fetal skull, just like that, in vertex presentation due to direct pressure of the cervix and the vaginal introitus during labor. Direct pressure of the cervix and the vaginal introitus on the fetal skull during process of labor. طبعا it is a physiological one, and it is usually present immediately after birth, and it usually disappear within 24 hours after delivery. It indicates there is no underlying fracture within the fetal skull bone, and it is diffuse and indicate no pathology affecting the fetus. The pathophysiology why the patient have cupped succedaneum, because of the effect of pressure of the cervix and the vagina. It will interfere with the venous drainage, venous return and lymphatic drainage, leading to stagnation of fluid and thus formation of cupped succedaneum. The other abnormality is the fetal hematoma, and from its name, hematoma is indicate collection of blood between the periosteum and the skull bone. It is usually occur within 12 hours after birth, and it is may last for about 6 to 8 weeks after delivery, and it is limited usually by the suture lines. It is although it is soft, but it is not biting, and it is may indicate fracture, underlying skull bone fracture. It is required no treatment, and usually the blood absorbs spontaneously, and the swelling subsides spontaneously. This comparison between the cupped succedaneum and fetal hematoma, usually as we see, the cupped succedaneum, it is present at birth on normal vaginal delivery, but the fetal hematoma a few days after birth usually appear, and usually following normal or even forceps delivery. It is in the cupped succedaneum, it is lie on suture and not well defined, while the fetal hematoma, it is well defined by suture. The cupped succedaneum, it is pitched on pressure, while the fetal hematoma, it is not pitched on pressure. The cupped succedaneum, it is ecchymotic, the skin is ecchymotic, while there is no skin changes in the fetal hematoma. Usually cupped succedaneum, it is gradually subside within days, but fetal hematoma may take 6 to 8 weeks in order to subside, and there is no underlying skull bone fracture in case of cupped succedaneum, but usually there is skull bone fracture in case of cupped succedaneum, but both are required no treatment. I hope you have understand what I want during this lecture. I'm ready to, if you have any question by the end of this lecture during Telegram. If you have any, I will be ready to answer. Thank you very much.